comments and questions, and before that, maybe I can start the rolling. Uh, can I start the questions here for you? Maybe some comments and then questions, and then we have some comments from there. I think before that, yeah, Dr. Deepika, please go
Do you
ahead.
want to first ask
Okay.
a question?
So, Dr. S.P. Singh, this is a comment for your presentation. You did mention about the role of environmental pollutants. And so, there's some data to suggest that, compounds like bisphenol A and B, they call BPA and BPB, they have all been associated with steatosis, but then the root again is through insulin resistance. And rather BPA, BPB compounds have also been shown to be associated with diabetes and other metabolic risk factors. So I'm not sure whether this is, other than they follow another route other than this. So this is about the BPA and BPAB. Arun, for you, I think just 2-3 comments. I think, we have this published ICON-D data of 1,000 patients where we compared the lean versus non-lean, and we found that even they have lesser metabolic risk factors, non-invasive severity and the histological severity, there is no difference between the lean and obese. And then we went on to say that, within the lean group, again that data is now published now, where we said that within the lean group, it is the central obesity. Because the definition of the lean problem was it was based on BMI. So in the nasal consensus, we suggested that, and now we have published that within the lean group, I think those centrally obese, I think they have a higher, that's an independent predictor of, their severity outcome. But the last but not the least is our unpublished data, which is under publication, where ORCA led that, ORCA Day led that study, where we did a randomized open label study of the usage of saroglitazar in patients with lean patients, and one group was given only lifestyle interventions, and the other group was given lifestyle intervention plus saroglitazar. So at the end of it, 6 months, what we found was that, at least the ALT reduction, and we took a level of more than 17 international units, which was shown to correlate with histology, was happening more, in SARO group. The dyslipidemia part was improving more in the SARO group, right? But we couldn't show the differences in the CAP and the fibrosis group. And maybe, Rohit, the one question for you, I think you can have one is, resveratrol probably will take some time to come to India. We have SARO and vitamin E here, but going beyond those, have you ever tried, and we have some experience of around 50 patients of using oral GLP-1, semaglutide, Rybelsus. We use these incremental dosage, and 50 patients data we have where non-invasively, again, we have shown the improvement in CAP and LSM in those patients. Any experience on oral SEMA, if you have had that?
Yeah, I think you could use that. The only thing is that it's just a lot more GLP packed into the oral therapy, because absorption of GLP-1 analogs are not sort of linear with the dose. And so that's the main issue. So each patient may have a very differential response with oral semaglutide. So I think you may have to just monitor the response, and their side effects could also vary depending on how well or how badly they're absorbing the drug. But I think, it's there.
Till the time, obviously, as I said, the Essence readout is yet to happen.
Yes.
So injectable will take, it's still not available.
Yeah.
So 3 months? Yeah, okay, 3 months. But then resveratrol, as I said, so going beyond the standard vitamin E and SARO, this is one which we have started using at least on our overweight and obese patients. And the tolerance, you said the GI side effects in our patients, 50 patients, was seen in around 65%, 2/3, but then there was no dropout. They all kind of, and there was bloating, belching,
yes,
all that stuff did happen, but then some elevation of amylase, lipase also happened, but then finally there was no dropout. That was the, thing. Anyway, let's go to the question from Deepika.
Okay, 2 comments I have for Dr. Singh. Since we in India have managed to introduce MASLD into our national program for control of diseases, 2 things can we not do as an association and recommend to the government. One is on all the sugary drinks. If we write that this causes liver disease and obesity on all the drinks, because you have all the film actors and cricketers and all endorsing it, and so people think it's okay to drink, because when you take a history from patients, they're drinking huge amounts of all these cold drinks. sugary drinks. And second is alcohol also. Like on cigarettes, it's written it causes cancer. Can we not have that written on alcohol and sugary drinks? We'll have to really push from INSL to the government to do so. But is it not possible?
Yeah, thank you, Deepika. Your suggestions are good and they need to be done. We have now a task force on preventive hepatology. We hope to have some consensus meeting on the very burning issues. And advocacy should be a part of every, as was highlighted by, either the Secretary General, Professor Craig, that advocacy is a must. We must be into advocacy, and we hope we'll be able to fulfill your desire.
Thank you.
Yes, Dr. Krishnadas.
My question is to Dr. Arun. So when we looked at our patients with lean MASLD and non-lean MASLD, we found that visceral obesity is less in lean MASLD as compared to the non-lean MASLD. But the ratio of the visceral obesity to total body obesity was much higher in the lean group. And another question is, you said that one of the slides, Faecalibacterium is less abundant in patients with lean MASLD. But actually, it is associated with obesity. So people with lean MASLD should be having a lower, higher amounts of Faecalibacterium. So do you think that is this bacteria is that important in patients with lean MASLD?
So answering your first question, sir, what they've said that within the lean mast cell there are different phenotypes, like type 1 and type 2 that I alluded to. One of them that is type 2, which is kind of associated with monogenic disorders and genetic disorders, are associated with lesser central obesity. So regarding the gut microbiome, what I wanted to show was that I did not want to show a pathophysiological relation, but just wanted to highlight the fact that the gut, even that gut dysbiosis that is seen in NAFLD, we initially thought it's just the same everywhere, but among the subset of lean versus overweight versus obese MASLD, the composition of the bacteria were different. Whether it has any clinical implication, we don't know. It was just a 13-patient, study in each group. So, it may be just an association. I just wanted to highlight the fact that the microbiome is, vastly distinct in all the phenotypes.
If I may add a couple of sentences to that, I think the microbiome field is still in its infancy. It is incredibly complex. Plus, if you obtain the stool in the morning and in the evening, there are very good publications from the diabetes world showing that your microbiome looks very different. And the interaction between the bacteria, there's something called quorum sensing, where the bacteria actually modulate each other's population. It changes, there's a diurnal cycle to that, and there are functional implications related to that. So a lot of these studies, because of this heterogeneity, when you see a p-value, the risk of false discovery is very high. So I think this is very early days. So functional data are needed, and that's where the field is moving towards. Now, in terms of the microbiome in MASLD, there are changes that occur in waves. At the very beginning, if you start feeding a high saturated fat or easily absorbable sugary diet, there's initial set of microbiome changes that occur in response to that, but those are not very prominent because most of those get absorbed in the proximal gut. Sugars and fats, most of those are absorbed in the proximal intestine. So they're not reaching where most of the gut bacteria are, which is in the colon. So then what happens is, as you start accumulating a little bit of fat because you're just in caloric overload, you get a little bit of cholestasis in the liver. You cannot get the bile acids out of the steatotic liver because the steatosis produces subclinical molecular inflammation, which affects the bile acid transporters in the caniculi. As a result, your bile acid levels go up early in the course, and when you decrease primary bile acids, then essentially what happens is these bile acids modulate the intestinal microbiome. And there are two broad types of bacteria in the intestine. One that are sensitive to the antibiotic functions of bile acids, and the others that only thrive in the presence of bile acids. So two very different populations. And so what you see is a progressive reprogramming of the structure and function of the microbiome, where you start losing the symbiotic bacteria, which are mostly sensitive to the antibiotic functions of bile acids. And then you basically get an overgrowth of different type of bile acids. And as this changes, then you get a third layer, because the bacteria that transform primary into secondary bile acids change. So you get a relative decrease in total secondary bile acids, but deoxycholic acid goes up. And deoxycholic acid promotes the growth of proteobacteria, which is what you see in all of these studies. So the microbiome changes occur in waves, and where the field is moving towards is really trying to understand the functional basis, because there's so much redundancy of function from one species to the next. It's really trying to identify a set of bacteria that serve a core function, and whether modulating it with phage therapy or something can actually modulate your physiologic status. So that's sort of, I think, that's the space to watch going forward.
Yeah, please go ahead.
Dr. SP Singh. SP, I just want to have one question for you. When I'm recording my history, it's a very basic question. In the personal history, I always ask in an IT patient whether he's working at Australia time, UK time, or US time. And then we have a set of patients who are working in 3 shifts. They are on first shift, second shift, and third shift. Amongst all these things, which becomes most relevant in chronobiology, which will be at a high risk for NASH? I mean, is there some work on this? Because definitely there are a large group of people who are in the NASH, and I don't know what to tell them because they just can't change their lifestyle anymore.
Yeah. Could you make your question a bit simpler?
Wow.
I think he's asking that if a patient or if somebody works a night shift, in essence, would that impact their disease versus somebody who is a day shift? To simplify what he asked.
Thank you, Dr. Rohit.
Thank you. Obviously, I mean, what the studies have shown is the patient who, when they work in night shift, there's a disruption in the circadian rhythm. This will affect all the metabolic parameters, even the gut microbiota, and what is the relation between them, we don't know, but they are more likely to have more fibrotic disease. I mean, these genes are expressed more in these patients. And I think, as I mentioned while I was going to start, that whether I will clear more of a doubts or some doubts will be cleared by the chairperson, Dr. Sanyal. I think he cleared a lot of doubts regarding microbiota. And I think most of the studies on microbiota, which are done with 17 patients, 20 patients, they are actually, to be very frank, meaning we have also done similar studies. They have no meaning. They can't tell us anything, right? You need large sample size, and only then, and again, you have to look at the metabolites, that the functional part. Then maybe we can tell whether there is some association. That's all. But unless we do over some time dynamic study in what changes are occurring, probably we may not be able to think of intervention at all. Dr. Sanyal, do you?
So I think it's really important for the type of patients if they're night shift workers, because this would definitely lead to changes in their diet itself. Typically people who work in the night shift potentially may consume greater carbohydrate-rich diet. And this could also be that the type of food that might be available to them during those hours. So I think an important nutrition regimen is critical in avoiding weight gain, because typically if somebody's working only nights, they're likely to gain more weight over the year compared to somebody who's working during the day. And then having a set exercise regimen would also be important for them. So I think a nutrition and a lifestyle prescription is key for everybody, but more so for anybody who's doing night shift work, and particularly monitoring their insulin resistance, however less important it might be in Orissa, but I think the rest of the world, it still remains important. And that would be a patient who could really worsen their insulin resistance.
One other layer to that, Rohit, is that particularly if the patient is already a little obese and they have little sleep apnea, then you're really compounding the effect of disruption of the sleep cycle with sleep apnea on top of that. And you know, NASH is a centrizonal disease. It's a zone 3 disease. That's the area with the lowest oxygen tension to start with. So if you compound it with a little sleep apnea and your oxygen level goes down, then you really accelerate the injury. If you look at the RNA profile in the centrizonal compared to the periportal area in NASH, the centrizonal area is a classic ischemia signature. And so that gets compounded. David Crabb showed this like literally 25 years ago. So we actually, as routine part of our NASH evaluation, sort of have sleep questionnaires and talk to the patient about sleep patterns and have a low threshold for getting sleep studies.
Yeah, maybe last question. Yeah, Dr. Piyush.
Dr. Rohit, the use of glucagon agonists, it increases blood sugar levels, it increases insulin levels. So isn't it counter-regulatory?
Excellent question. Yes. Glucagon agonist by itself would be a kiss of death for any patient who's got diabetes and steatohepatitis. That's why you would want a combination approach. And with the combination approach, you can actually squeeze in greater weight loss with depending on the ratio of GLP to glucagon. And so that's why the only clinical utility of now glucagon agonism is in the setting of a GLP-1 analog combination or potentially GLP plus GIP. And particularly being liver active, I think you will see greater use and multiple drugs coming in this domain with combination approaches with glucagon GLP for treatment of NASH or fatty liver disease. Because if you give GLP-1 alone, your say liver fat changes maybe 40% reduction. When you add that glucagon on top of it, you will go to 60% reduction because of its liver-centric action. So yeah, you don't use it as monotherapy. It will not be coming to you. It won't be available.
Safe to use for diabetics?
Yeah, it's definitely safe to be utilized in diabetes depending on the combination of those two.
Yeah, I think it's very important to remember just because something is a GLP glucagon coagonist doesn't mean they're all the same. So it's one molecule that is binding to both receptors. So the affinity for one receptor could be 90% and the other one 10%, could be 50-50, or could be 10 and 90. So what you need is a optimized ratio of GLP activity and glucagon activity where you have just enough glucagon to promote mitochondrial oxidation, improve mitophagy and generation of new healthy mitochondria, but not enough glucagon to actually produce hyperglycemia. So there are some coagonists that have been developed in phase 2 where you see no glycemic benefit. So those molecules are unlikely to go forward because you've lost the glycemic benefit of GLP-1. And so the molecules that are moving forward maintain their glycemic benefit and reduction of A1C on top of whatever background therapy they're getting, and they're getting the liver benefit also.
So just one last question
sure,
to both Dr. Luba and Dr. Sanyal. So taking the same question forward with Dr. Duseja had put up, since we do not have resmetirom coming in India, and we already have OCA, and you already have experience of OCA. I understand it's not FDA approved yet, but at lower doses, if we want to use it in patients who have beyond F2 fibrosis, say 10 milligram per day, would you encourage it or discourage it? And why?
It's available and approved for PBC in India.
We can
So it's
easily,
available, yeah.
We can easily...
Yes. No, I remember that.
We can off-label use it very easily. So
Yes. Now I know the ease, and that's where the dis-ease comes. So just the history on OCA I think it was a few years ago, Dr. Reddy's lab and we reviewed the entire data, and I think Anil Rora was there at the Indian analog of FDA. And we had this discussion about the safety of this particular drug for treatment for PBC at 10 milligram dose. And people had a lot of concerns. They were solved, and eventually, I think this meeting was Thursday, and by Monday, the drug got approved here. I think that was rare disease. I would not advocate for treating with obeticholic acid, given that it hasn't been approved in the United States, with concerns that the FDA had safety concerns. Although Arun and I advocated for that drug to be approved, and we were, presenting our case to the FDA. But given that there's a regulatory hurdle on the other side, I would caution against using it, because I think Ajay or if Kaushal, you use it, there might be somebody else outside who might take it that that Dr. Duseja used it or somebody else used it. They will use it in a wrong patient.
I agree with you.
That could be an issue.
So in that scenario, I'm sorry, we are shooting time. The combination of vitamin E versus saroglitazar, any thoughts on this?
Yeah, I think Dr. Anand had that paper for me to review, and at least from that paper, I think it was from the Indira Gandhi University in Shimla, and I think it looks reasonable. I think there should be a phase 4 type study where maybe INASL should conduct and look for a 1-year data in patients who have maybe elevated ALT, maybe similar to our VEDS trial. We can share that protocol with you, and you can take that and do a combination approach with that. That might be a better way to do it.
Yeah, actually in your ICON-D, you have 8,000 patients now. I'm sure there are 100 patients who are on both. At least 100, right, out of 8,000. I'm not asking for much. So look at that data. I think that would be very useful. Sorry.
Okay. So thank you very much. I think all these speakers, and thanks to all the chairpersons. I think this is a good discussion. Thank you. We close the session. Thank you.